Dr. Ferraro for a wonderful presentation. Very thought-provoking. And to put this all together, our next presenter is Dr. Ciara O'Sullivan from Mayo Clinic, who will be presenting virtually, oh, not virtually, yay, who will be presenting her synopsis of the meanings of all of these. Thank you, Ciara.
Good morning, everyone. Good morning, everyone. My name is Ciara O'Sullivan, and I'll serve as the discussant for the preceding abstracts. I'd like to thank the organizers of San Antonio very much for the opportunity and congratulate the presenters. These are my financial disclosures. My presentation this morning will include a brief overview of treatment for metastatic HER2-positive breast cancer in 2021, our current standard of care. I'll also discuss the 3 abstracts reviewed this morning prior to providing a brief perspective on optimizing systemic therapy in HER2-positive metastatic breast cancer by addressing a number of key questions in our field. Prior to the advent of the HER2-targeted monoclonal antibody trastuzumab, HER2-positive breast cancer was associated with high recurrence risks and inferior survival. Landmark trials demonstrated that the combination of chemotherapy and trastuzumab dramatically improved oncologic outcomes in both early and late-stage disease. Today, there are 8 FDA-approved HER2-targeted agents, including 4 that were just approved for use in the last 2 years. However, despite this rapid progress, the majority of patients with HER2-positive metastatic breast cancer sadly die of their disease. Therefore, studying mechanisms of resistance and identifying predictive biomarkers is a research priority. Further, the increased survival of patients in the metastatic setting has been accompanied by an increased incidence of breast cancer brain metastases, which is an urgent unmet clinical need. First-line standard of care systemic therapy for HER2-positive breast cancer remains a taxane, trastuzumab, and pertuzumab. Based on the results of the Cleopatra trial, which showed a 16-month overall survival advantage when patients received docetaxel, trastuzumab, and pertuzumab compared with the control arm. However, second-line options have recently rapidly evolved. Since 2013, oncologists have commonly been prescribing TDM1 based on the results from the Amelia trial, which showed a superior progression-free and overall survival advantage when patients received TDM1 compared with lapatinib and capecitabine. More recently, the NCCN guidelines have listed tucatinib, capecitabine, and trastuzumab as both the second and third-line option in this setting, based on results from the HER2 CLIMB trial, which showed notable progression-free survival and overall survival advantages in the tucatinib-containing arm, including in approximately 50% of patients who had brain metastases at enrollment. Now, given the striking results from the DESTINY-Breast03 trial, trastuzumab deruxtecan is poised to further impact the treatment paradigm. Key questions moving forward relate to what the best treatments are in the first and second-line setting overall, as well as to how we can optimally position tyrosine kinase inhibitors in the treatment paradigm, given the known success of trastuzumab deruxtecan. Furthermore, multiple novel agents are under evaluation in clinical trials and may impact treatment sequencing decisions in the years to come. I will now review the first abstract presented this morning by Dr. Hurvitz, trastuzumab deruxtecan versus trastuzumab emtansine in patients with HER2-positive metastatic breast cancer, results from the DESTINY-Breast03 trial. Antibody-drug conjugates combine an antigen-specific antibody backbone with a potent cytotoxic payload. The prototype antibody-drug conjugate, TDM1, combines trastuzumab with a maytansinoid DM1 and is FDA-approved for use in the second-line setting. Trastuzumab deruxtecan, conversely, has a higher drug-antibody ratio and inhibits topoisomerase I versus microtubules. It is FDA-approved for patients who have received 2 or more HER2-directed regimens for metastatic disease and was recently granted breakthrough therapy designation as a second-line option based on data from DESTINY-Breast03. A notable side effect of trastuzumab deruxtecan is interstitial lung disease. DESTINY-Breast03 was a randomized, multi-center, global phase 3 trial which enrolled patients with HER2-positive metastatic breast cancer with or without brain metastases. Randomization was 1:1 to either TDM1 or trastuzumab deruxtecan. The primary endpoint was progression-free survival by blinded independent secondary review. Key secondary endpoints included overall survival and safety. A pre-specified subgroup analysis for progression-free survival included several factors, as well as brain metastases at the time of enrollment or a history of same. Results were initially presented at the ESMO Congress earlier this year. We can see that the hazard ratio for progression-free survival was 0.28, median progression-free survival of 6.8 months in the TDM1 arm, and not yet reached in the trastuzumab deruxtecan arm. Today, we saw a consistent progression-free and overall response rate benefit with trastuzumab deruxtecan across patient subgroups. Importantly, trastuzumab deruxtecan was tolerable and manageable, and there was no incidences of grade 4 or grade 5 interstitial lung disease. As it relates to the brain metastases analysis, we can see that trastuzumab deruxtecan was associated with a substantial improvement in intracranial response rates and reduction in CNS disease. Overall, the cumulative efficacy and safety data support use of trastuzumab deruxtecan as a new second-line standard of care for patients with HER2-positive metastatic breast cancer. A key question moving forward relates to what is the best treatment for HER2-positive breast cancer brain metastases. Given the limitations of cross-trial comparisons, how do tucatinib and trastuzumab deruxtecan compare? The red box highlights data from the HER2-CLIMB study, which enrolled 291 patients with brain metastases. We can see that the addition of tucatinib to capecitabine and trastuzumab increased the CNS overall response rate to 47.3%, doubled median progression-free survival, and prolonged overall survival by 6 months. The purple box highlights data from the brain metastases analyses from DESTINY-Breast01 and 03. The latter trial included 82 patients with brain metastases. We can see that there was an impressive improvement in the CNS overall response rate to 63.4% in the trastuzumab deruxtecan arm, and median progression-free survival was prolonged by 12 months. Overall, it remains to be seen whether tucatinib, trastuzumab deruxtecan, or both can prevent relapses with brain metastases in our patients with early-stage, high-risk disease. I will now move on to discuss the next abstract presented this morning by Dr. Xu et al., which provided us with an updated overall survival from the phase 3 Phoebe trial. Tyrosine kinase inhibitors are an important treatment option for patients with pretreated HER2-positive metastatic breast cancer. They differ by molecular weight, her protein specificity, reversibility of binding, and by their side effect profiles. TKIs also have varying degrees of effectiveness against brain metastases, and lapatinib, neratinib, and tucatinib are FDA approved for treatment of HER2-positive metastatic breast cancer. Paratinib, specifically, is a second-generation irreversible pan-HER receptor TKI targeting HER1, HER2, and HER4. The phase 3 Phoebe trial was conducted at 29 centers across China. It included participants with HER2-positive metastatic breast cancer who had received 2 or less lines of chemotherapy in the metastatic setting to include a taxane and trastuzumab. Randomization was 1:1 to either oral daily lapatinib or oral daily paratinib, both given in conjunction with capecitabine on a 2-week on, 1-week off schedule. The primary endpoint was progression-free survival by blinded independent secondary review, and key secondary endpoints included overall survival and safety. Results from an interim analysis were presented last year. We can see that there was a statistically significant progression-free survival advantage favoring paratinib and capecitabine at 12.5 months versus 6.8 months for patients who received lapatinib and capecitabine. The overall survival data at that time were immature, and in July of 2020, paratinib and capecitabine was approved as a second-line treatment for HER2-positive metastatic breast cancer in China. Today, we saw updated results from the overall survival analysis shown to the right of the slide. We can see that the median overall survival was not reached in the paratinib group and was 26.9 months in the lapatinib group. Subgroup analyses of overall survival and progression-free survival reaffirmed the benefit of paratinib and capecitabine across most of the clinically relevant subgroups, reaffirming this treatment choice as a second-line HER2-positive metastatic option in countries or regions where antibody-drug conjugates are not accessible. Furthermore, given the activity of paratinib, it could be considered for international use. However, the treatment landscape for HER2-positive metastatic breast cancer is becoming increasingly crowded. Key questions when making treatment decisions relate to the potential for treatment toxicities and patient comorbidities, the activity of a purported compound or regimen against CNS disease, as well as progression-free survival and overall survival data. Given the striking results from DESTINY-Breast03, trastuzumab deruxtecan will now replace T-DM1 as the new second-line standard of care. However, tucatinib, capecitabine, and trastuzumab remains a good option for patients whereby medical comorbidities preclude use of trastuzumab deruxtecan or in situations where optimization of intracranial response rates is desired. Other key questions going forward relate to the activity of T-DM1 after trastuzumab deruxtecan, as well as the activity of neratinib after a tucatinib-based regimen. Furthermore, there are multiple novel agents which are presently under evaluation, which will likely influence sequencing decisions in years to come. The last abstract I'll review this morning was presented by Dr. Ferraro et al. And entailed a genomic analysis of 733 HER2-positive breast cancers. Approximately a fifth of patients with early-stage HER2-positive breast cancer and a quarter of those with metastatic disease display either primary or secondary resistance to HER2-directed therapies. Therefore, unraveling mechanisms of resistance is crucial in order to improve patient outcomes. To date, HER2 status remains the only clinically validated biomarker. Promising biomarkers which may inform treatment decision-making and provide prognostic information in the future include HER2 levels and heterogeneity, HER3, intrinsic molecular subtypes, DNA mutations, and immune-related factors. An awareness that disease phenotype may change between primary and metastatic biopsies is also important. The goal of the project presented by Dr. Ferraro et al. Was to identify ways to prevent disease progression by elucidating mechanisms of resistance to HER2-directed therapies via analysis of a large cohort of genomically and clinically annotated HER2-positive breast cancers. We can see that genomic analysis of the primary and metastatic samples identified, as expected, concurrent mutations in the PI3K AKT pathway, including in PIK3CA 30%, PTEN 2.6%, and in AKT1 0.3%. The authors also noted an increased frequency of mutations known to activate MAP kinase pathway signaling in metastatic as opposed to primary tumor samples. Given the known impact of PIK3CA mutations on response to HER2-directed therapy, an outcome analysis was conducted. This included 145 patients who were sequenced prior to commencing first-line therapy with THP for metastatic HER2-positive breast cancer. We can see that there was reduced progression-free survival in patients whose tumors harbored PIK3CA mutations, lacked ERBB2 amplification by next-generation sequencing, or possessed a MAP kinase pathway alteration. The authors also sought to validate these findings in vivo and in vitro. We can see that in NF1 silent cells, HER2-positive breast cancer cells were resistant to HER2-targeted TKIs such as neratinib and tucatinib, but sensitive to MEK/ERK inhibition. The sensitivity to MEK inhibition was confirmed in vivo, alone, and in combination with HER2-directed therapies. Overall, these data are important as they infer that MAP kinase pathway alterations are an acquired and targetable resistance mechanism to approved HER2-directed therapies. Overall, in summary, results from DESTINY-Breast03 show that T-DXd is a new standard of care in the second-line treatment of HER2-positive metastatic breast cancer. Results from Phoebe affirm paratinib and capecitabine as a second-line option in countries or regions where antibody-drug conjugates are inaccessible. Furthermore, the genomic analysis presented by Dr. Ferraro highlights that targeting the PI3K or MAP kinase pathway could extend the benefit of HB-based treatments. As it relates to the best HER2-directed therapy overall, we are still using THP in the first line. However, trials incorporating frontline T-DXd and tucatinib are ongoing, and results are eagerly awaited. As it relates to the optimal second-line treatment, T-DXd is a superior antibody-drug conjugate as it relates to clinical efficacy and will replace T-DM1 in this role. The current role of the TKIs in the T-DXd era is, in some settings, the third-line setting. However, the combination of T-DXd and tucatinib is presently under evaluation in the HER2-CLIMB-04 study. Further, tucatinib, capecitabine, and trastuzumab remains a good second-line option in select clinical circumstances. As it relates to the best therapy for prevention and treatment of brain metastases, several compounds have shown efficacy. However, most data in the metastatic setting remains for tucatinib at this time. Adjuvant trials will determine if trastuzumab deruxtecan, tucatinib, or novel approaches can prevent relapse with brain metastases. And intriguingly, we may be able to use genomics as early as the first-line metastatic setting in future to tailor and sequence therapy. Thank you.
Thank you, Dr. O'Sullivan.